Good afternoon.
Hello, everybody.
Just checking everyone's joining us.
Welcome to the CareFlex May webinar. It's looking at specialist seating for those with neurological impairments. If we've not met before, my name is Les Jones. I'm an assessor with CareFlex and I'm joined by my colleague Rebecca Dunstall.
Good afternoon.
Rebecca's our clinical lead. If I just leave Rebecca wander across the stairs, set up the presentation. A little bit of housekeeping. We are recording the session, so just be aware. If you need a link for a copy, we can post that to you via the chat feature on the Teams app. Just in general, this is just one format that we use for our training. Various other formats as well. We can come and visit you to do smaller group sessions. We can do tailored virtual sessions a little bit like this, or we have a series of roadshows. Our next roadshows are in the southeast. If you'd like to come along. I keep forgetting the date, Rebecca.
24th and 25th of June.
I think it's the 24th and 25th of June. So if you want to check on our website, or we will be sending you, or Kiwi, my colleague who's monitoring the chat feature, will send you a link to those. So without any further ado, I'll pass you on to Rebecca.
Thank you very much, Les. Let's get the presentation up. Hopefully technology's with us and that's on your screen. Good afternoon, everyone. As Les said, what we're doing today is exploring the principles of effective postural care and sitting for individuals with neurological impairments. We are going to focus on understanding common postural challenges and how well considered seating can promote things like comfort and function and participation. The aim is for you to gain practical insights into clinical reasoning and learn some simple transferable strategies to optimise sitting posture across daily activities and daily life and those real world contexts. By the end of the session, I'd like you to feel more confident in recognising common postural presentations that we may come across in individuals with neurological impairments, understanding what's driving them and applying simple but effective seating strategies in practice. We'll focus on transferable principles, things that you can use across a wide range of individuals, not just specific diagnoses. Let's start by setting the record straight. Body distortion is not inevitable. With the right approach, equipment and positioning, we can protect body shape, support function, and ultimately improve quality of life. And this is exactly why we're stepping away from condition-based thinking today. This quote always sticks with me. It's more important to understand the person than the disease. Even two people who share the same diagnosis, their presentation, their goals and their needs can be completely different, and that's central to everything we're discussing today. So before anything else, we have to prioritise the individual, that person-centred approach. That means understanding their goals, understanding their daily life, their environment, and working with them as equal partners. And when we do that well, we build trust and ultimately get much better outcomes because they are engaged in our intervention plan. They're motivated to participate with that. We start our assessment subjectively. Make sure I'm on the right slide there. Yeah, there we go. We start our assessment subjectively. Sorry, kept skipping forward then. Because posture doesn't exist in isolation. It kind of underpins everything we do throughout daily life, from movement and transfers to mobility and function and the engagement levels that we can achieve and participation in meaningful life. So we need to understand the person, what matters to them, what their goals are, how they function day to day, and what their environment might look like. This includes things like their cognition, their communication strategies, how they manage fatigue or movement throughout the day and night. Because without that context, we risk prescribing something that looks right clinically, but doesn't work in real life. We can reframe this subjective assessment process into three areas. So first of all, the person, their goals, expectations, any relevant medical history or risk factors that we need to be aware of. the context, so their social history, their environment, their support needs, who we may be relying on. Sometimes we can't be there 24/7. Sometimes we can't hold caseloads. We have to discharge. So when we step away, we often rely on the support network to be able to continue, the principles of the intervention to get those outcomes. And then how all that relates to functional engagement, the activities of daily living, hobbies, occupation, mobility, transfers, any current equipment as well, because when we talk about postural care, it is a 24-hour approach, and how we rotate around equipment and achieve different objectives from that. Then we move into the objective assessment, so the physical assessment, getting hands-on. We're looking at posture in sitting, or also in supine, because that helps us understand what is flexible and what might be fixed. Now, I appreciate I don't know everyone's clinical settings, and a lot of you may be community-based. You might not have access to clinics or to high-low plinths or the tools that might be needed, and we can only work with the resources we have. There are different things that we can do to be able to assess in more detail in sitting and in supine, which may be a bit of a compromise away from the gold standard, but even doing something is better than doing nothing. And when we're having a look in sitting and supine, we do get to see the difference of what is achievable when we kind of take elements of gravity away, allowing people to settle into different support surfaces to really see what the body limitations are. We need to be able to better understand that balance between correction and accommodation. We're considering things like alignment, postural control, sitting balance, and what level of support may be needed. Understanding range of movement and how that applies to the critical angles for sitting are vital to ensuring the correct chair setup, and we'll cover that a bit later when Les gets the chairs out and talks through things that, like seat depth, seat width. It's also an opportunity to use outcome measures to get clear baseline data, objective where possible as well. So it gives us that comparison when we do our review process, or if any issues can come up in the future. And one really key point here is understanding how the individual communicates discomfort or pain, especially if they are non-verbal or they use alternative communication strategies. Because if we miss that, we can easily misinterpret their presentation. I've worked with individuals who giggle or chuckle when they're actually in pain. So we need to understand the context of that communication. Now, that was a whiz through, I appreciate, of assessment, very surface level. We do have other webinars with more focus on this part of seating prescription. But Les touched upon it just now around our clinical study days. That's what's best placed really to support further learning around assessment, especially around hands-on practical practice and assessment techniques. So yeah, please do reach out to us if that's something for in your region. You can come along and spend the day with us going into this in a bit more detail. Now, this is my take-home message slide. Do not underestimate the importance or the power of your clinical reasoning skills. We have to use that assessment process that we just covered to determine the dominant drivers of postural change. Visible presentation does not always correlate to the most obvious cause of that postural challenge. For example, it's great to know that an individual presents with a pelvic obliquity and rotation, but do you know why that's happening? Is it intrinsic factors such as abnormal tone that's pulling them into that position? Is it an undiagnosed hip subluxation? So they're experiencing pain and they're going into that guarded, they're adopting that guarded pelvic position to be able to open up the hip angle for comfort? Or is it simply an external factor such as their positioning in the chair, their initial positioning, or us not understanding what their focal point of interest is? So they have this compensatory rotation in the chair just to be able to see what they actually want to interact with. Now, the solution to these 4 scenarios alone will be vastly different. the right solution depends on understanding that problem list, not just recognising the posture in front of us. So we have to define the dominant driver, which then also allows us to prioritise the seating principles, and we'll look at that shortly. So please just remember to invest in some time in the clinical reasoning following that assessment process. Check that you understand what's driving the posture, whether it's tone, weakness, fatigue, fixed deformity. It could be, the extrinsic factors, equipment related, environment, caregiver input, and it could be a combination of all these things. But we have to understand that dominant driver, getting hands-on, doing a bit of postural detective work to see actually what's causing that presentation. The strategies that we are going to discuss shortly are not a checklist. They're not a rigid prescriptive solution. They have to be applied based on this clinical reasoning and individual need, but hopefully will provide you with some ideas, some hypothetical scenarios to be able to take away and think about, and then hopefully apply that reasoning to your clinical practice. And again, that's why we're there to support you as well when we collaborate on things like the seating assessment. Once we've completed our assessment and understood the dominant drivers, then we can move into seating provision. And this is where that clinical reasoning really comes into play then. We have to start with the basics. This is actually one of the parts that's most overlooked, especially where maybe within multi-user environments or where chairs are being recycled or reused between individuals, and we're not adjusting things like the seat depth and the seat width. So we have to make sure that the chair is set up correctly to the individual's body shape and body size. Then we can build in support from the pelvis, but then moving on to all the other body segments as well, even the feet, considering what can be corrected and what needs to be accommodated. Then we carefully consider the selection and safe use of things like tilt in space, back angle recline and leg rest elevation, and whether they're safe and appropriate. We actually done a webinar a few months back specifically on the safe use of these functions. So again, that might be something to recap on, because there are going to be certain situations, especially what we might see with the neurological impairments, where we need to be very mindful of how to use tilt appropriately. Especially if somebody has dysphagia, if they have a swallow dysfunction, if there's an aspiration or choking risk, is there an eating and drinking profile in place? Do they have medical devices in situ? There has been cases where, severe tilt can affect things like backflow with a catheter, communication, assisted communication devices and eye gaze. Just be mindful of, how somebody's positioned, how functional tilt might be for them. If tilt is appropriate, how much tilt, how much degrees of tilt, and for how long after food. And these are all things to think about and input into the care plan. The same goes with back angle recline and leg rest elevation. If somebody doesn't have the critical angles, such as knee range of movement to tolerate that, we're going to be negating all that hard work we do. So is it evident in the care plan not to adjust back angle or not to adjust leg rest elevation for some individuals? And then finally, and I guess the most important part of this process is really the implementation, which means a clear, simple care plan that makes sure that everyone who's involved in that understands how to use the chair as safely and consistently, making sure it fits into daily life and is something that can be replicated day after day. If that last step isn't done well, then the whole intervention can fail, and all that hard work that we've put into the assessment and the clinical reasoning will fall. Regardless of the individual, these key principles always apply and underpin everything that we do. For me, the top priority is always comfort, regardless of the clinical objectives. If the user isn't comfortable within the chair, then they're simply not going to use that piece of equipment, and we're definitely not going to achieve our clinical objectives. We have to have that compliant and consistent engagement with the piece of equipment or the intervention. And then, of course, postural care, pressure care, functional engagement, health and safety, not only keeping them safe within the chair, but also the health element as well, and promoting optimum physiological function, for example, reducing the risk of falls, and then how all this feeds into well-being and making sure that we are elevating quality of life and not restricted elements. A big part of that is the interaction and engagement that people can achieve by getting out of bed, for example, being able to maneuver around the environment, be able to remove their arms from a load-bearing role to engage in activity and get a good line of vision to interact with family and loved ones. Okay, let's just do a quick activity then. If you're able to do so, then please do participate. You know your own bodies and whether it's safe for you to do that. But if you are able to, then please do. It's only a very quick activity. I'd like you to adopt a destructive sitting posture. Maybe you have a kyphotic position. Maybe you have some wind sweeping where the lower limbs are rotating over to the side, which is pulling your head position. Maybe you have a heavy lean happening to one side. Maybe you don't have foot support and you're trying to balance and perch on the chair. Then if you're able to turn your screen away from you slightly, move your notepad or your pen away from you. And then I'm going to make you sit like this for the rest of the talk. I'm joking, I'm not going to make you do that. You can go back to your comfortable position now, but just notice what your initial reaction to the possibility of having to sit like that, so unsupported, so uncomfortably, and so detached from the activity that you're trying to engage in. And imagine that's your real life situation that's repeated hour after hour, day after day, possibly year after year. And sadly, that is the reality for many individuals that we work with. And that's why postural care matters. And sometimes this is a really helpful activity to do with individuals and support networks and caregivers if you're really struggling to get that engagement and compliance, or if you're trying to change that lack of understanding into why we're doing what we're doing and why we're investing so much time in it. So let's start then with our focus on some neurological, neuromuscular, complex disability client groups that we may see within our clinical practice. Again, you may be working in the community and you're working with individuals who present with all of this. Maybe you work within stroke rehab or neurological rehab with older persons, maybe within dementia care, learning disabilities, where you might be working with a specific client group. But what I want to do today is to move away from this focus on diagnosis and instead look at some of the common postural presentations and the patterns that we see that can relate to neurological impairments. Things like asymmetry, reduced trunk control, pelvic and postural instability, fatigue, abnormal movement patterns and reflexes, fluctuating presentations, sadly sometimes progressive elements, or even rehab potential where we're hoping to improve situations. We might see the more complex end of the spectrum where there is a risk of contractures from limited range of movement and tonal changes. We may be working with individuals with sensory changes or sensory impairments as well. So what we're going to do is kind of work our way through some of these common presentations where there's often a low overlap regardless of the diagnosis. But just remember that the caveat is that, yeah, we can understand this presentation, we can understand the implications of it. The assessment is important to understand the driver and the cause of it. So let's start with the foundation, or what's historically been the foundation for sitting, the pelvis. Now, regardless of the diagnosis, if the pelvis is not stable, the rest of the body cannot function efficiently. We have to have that proximal stability to enable distal control. Otherwise, the upper limbs take a load-bearing role. You start seeing people hanging onto the side of the chair, digging elbows in, leaning heavily, because they're having to use their upper limbs to seek that stability. And the same goes with on the next slide when we see kind of trunk control issues as well. They start taking that load-bearing role. We can see things like a posterior pelvic tilt, so sacral sitting. There may be an obliquity where one side is higher than the other. Rotation, you'll see in this image here how they display in all three of those postural challenges. That can result in this movement in the chair, this unintended movement in the chair, destructive movement in the chair, and potentially how we then develop these poor habitual positions. The impact of that, of course, is things like associated challenges. We may see a kyphotic position, for example, with somebody with sacral sitting, individuals who have extensive spasms, where maybe they're going into that anterior tilt, can suddenly lose that functional reach and interaction. There's, of course, with that movement in the chair, and unequal load on tissues, we can see an increased pressure risk, but also sit intolerance as well, because who is going to want to sit in such an unsupported position for prolonged periods of time? And there may be cases where people are having to go back to bed, again, confined to bed for prolonged periods of time. So what we're aiming to achieve is that stability with the pelvis as far back in the chair as possible, so that we get in that posterior and lateral support at the pelvis. We, of course, need to make sure that the seat dimensions are correct, because if the chair doesn't fit, nothing else will work. Then we can look at the interface, things like the cushions and the contouring, supporting the ischial tuberosities, working out whether we need to correct or accommodate some of those pelvic movements. In some cases, we may then use positioning aids or flexible postural supports, always starting with the least restrictive option, of course. We can utilise different features, such as tilt in space, particularly for those who are struggling to maintain the position against those gravitational forces. The key message here is that once the pelvis is stable, we've significantly improved their ability to sit, to function, and to engage. But even though the pelvis is, long-standing believed to be the foundation for sitting, it's not always the focus. For example, if someone has habitual wind sweeping posture, and over time they've compensated by rotating the head for their line of vision, so they've rotated their head back to midline, where the rest of the body has been in this wind sweep rotated position. If we focus on correcting the pelvis back to that midline, we're going to throw out that safe head and position that they've developed over time. So again, it's about understanding, that balance, but also being happy with compromise when it comes to postural care. There's no such thing as a perfect posture. And even if there was a perfect posture, we still wouldn't maintain that for 6, 7, 8, 10 hours a day. We still have to have a regular change of position. So, sometimes there is an element of compromise, and we'll kind of look at this in a bit when we look at the key principles of seating and some of those competing priorities that we might come across. A big thing for postural stability is getting that proprioceptive feedback within the chair. So when I talk about proprioception, is kind of, believed to be our sixth sense, our body awareness, knowing where our body segments are in space without any visual cues. And sometimes people with neurological impairments, especially if they have abnormal movement patterns, that proprioceptive work, getting as much in contact with the chair as possible. Sometimes deep pressure work, using that weight distribution to get that deep pressure in the chair allows them to get a better sense of where they are. Another key point, another tip to mention, especially if those of you who work with individuals who have that proprioceptive challenge, so they don't know where midline is. So, for example, within Parkinson's, they may be leaning to one side, not because of changes in tone, not fatigue, but actually because that's where they think midline is. So sometimes mirror work, making sure that when they're in a sitting position, there's the mirror in front of them, so they have that visual cue to be able to correct and prompt that change in position. Once we have that pelvic stability, we can then start addressing the trunk alignment to be able to support function and physiological health. Research has shown that if somebody lacks the ability to maintain that upright trunk position, it's primarily reflected in things like physiological dysfunction, reduced respiratory and digestive efficiency, even cardiac efficiency. The impact that has on swallow function and safety with eating and drinking. We can see individuals with poor upper limb function because they could be taking that low bearing role that I mentioned and having to support the trunk, which could then mean that because the body segments are working inefficiently, that they have fatigue and reduced engagement and interaction. We can then also have those compensatory head positions that I mentioned, which then adds another challenge when we're trying to correct positions, because we have to deal with those potentially reversible changes that have happened over time. What we can see is this, what it presents as visually then is that collapse or asymmetry within the chair. But again, that's just the presentation where we need to understand the driver of that. So we're thinking about here, about target, is it intrinsic or extrinsic? Is it a combination of both? And then we can start thinking about some of these solutions, such as the choice of back support and back shape, contoured flat backs, waterfall backs. Does somebody have a particular asymmetry where they are needing 2-point lateral support and maybe 3-point? Then working our way up to more complex presentations where we need that multi-point, multi-segmental support. And this would make a lot more sense when we get the chairs out later and you can actually see the different backs, back style options. Using things like tilt in space as a period to rest and recuperate, as long as that's appropriate for them. But really understanding, what the causes are and coming up with the solutions to balance whether we are correcting or accommodating. What I would say about trunk support is a quick check to see if we're supporting adequate enough is if you remove the arm support. So if you notice that if somebody is using the arms on the chair, taking that support away for a period of time to see actually what happens at the trunk. Do we then suddenly get a collapse when we take that support away? The arms of the chair should only be taking about 2% of their body weight. It's there to be able to enable them to reposition potentially, maybe for activities and engagement, not to support the trunks. That's a quick check you can do to make sure they're able to be supporting the pelvis and trunk adequately. Moving up to the head body segment then. And again, this isn't just about posture, it directly influences things like their safety and their swallow and their communication. And I find this actually one of the most challenging body segments, just because the very nature of head support can be potentially rigid. It can be quite limiting, maybe affecting things like peripheral vision. And there are solutions that we can work around, but often there's a bit of trial and error to understand their personal preference. In terms of their comfort, it might be a case that we need to think outside standard prescription and think about more tailored solutions. Is there ways of utilising head support that's already working well and integrating that into the chair? The important thing is getting as midline as possible, as upright as possible without fatiguing too quickly. Another challenge for this is, of course, the other body segments. If somebody has a kyphoscoliosis or quite extreme kyphotic positions, again, the line of vision is suddenly down to the ground. How do we better improve interaction and engagement and communication, especially if somebody relies a lot on lip reading and eye contact? So yeah, I find this really challenging, a lot of trial and error, but that's something we can kind of work through during the seating assessment. But also thinking about that fatigue management, and we'll cover that shortly. As I said, there are different options, things like articulating headrests, adjustable headrest, lateral supports, flip away lateral supports to help with moving and handling. And it's just really about optimising their alignment and stability, but also being able to have the tolerance and endurance to maintain that. The head is a heavy body segment. So even though we talk about the pelvis affecting other body segments, the head is actually a driver sometimes for challenges elsewhere in the body, because where the head goes, the body tends to follow. And sometimes we kind of miss that link and blame everything on the pelvis. So again, thinking about the environment and where focal points are, where they need to interact, where's the table kept, where are all their hobbies and interests kept? Is it only to one side, in which case they're having to rotate to be able to reach for that? So it's just thinking outside of the box sometimes. Another probably common challenge that we see within neurological impairments is things like those abnormal movement patterns, changes in muscle tone, the instability that can come with that, and the risk factors. You might work with individuals with dystonia, choreic movements, ataxic movements, a combination. And what this tends to do is disrupt posture, of course. Of course, those kind of movements are going to disrupt the positioning that somebody is able to achieve. Our role isn't always to stop movement. In some cases, we can manage it better. We can use things like postural stability, pelvic positioning, that proprioceptive feedback to try and dampen down some of those impairments. But often we're just trying to support it as safely as possible, which then, you know, if we are able to impact, for example, if somebody has an extensor thrust, and we are able to limit some of those unexpected movements through things like reducing the hip angle, getting that pelvic stability, ramping the cushion, or using contoured cushions, for example, then of course we're going to do that. Those are the least restrictive options possible. But in some cases, it's just allowing that freedom of movement to happen, but doing it in a safe way, in which case we're looking at a very different seating system to do that. And again, Les will run through that, where the priority is going to just be safety within the chair, and the chair looks very different when we kind of show you the difference between something like the multi-adjust, where we are, or the Smarty Pro, where we are successfully dampening down those movements, compared to something like the Alpha Care, where we're allowing those movements, but in a more safe way. There are going to be fluctuations in this as well, which adds another challenge. There could be sudden shifts in posture and trying to be reactive to that. And, you know, in the care plan, again, do we need different positioning strategies for different days in how somebody presents? A lot of the time, some of these involuntary movements and reflexes can be dictated by mood. You know, if somebody is excited or agitated, we can see those fluctuations happening, and there may be a different response needed to manage that. So as I said, you know, working on that stability, getting a supportive base, reinforcing the postural stability, trying to get as much proprioceptive feedback at all the body segments, using contoured surfaces to guide that alignment where possible, utilising tilting space to recruit gravity to help with that control, and then working our way up then to potentially positioning aids like 4-point belts and groin harnesses, obviously with the risk assessment in place. But then if we are thinking those movements just need to happen, but we still need to sit someone out safely, do we need to think about padded elements or more robust components to reduce that injury risk, but also longevity of the chair as well? I've touched upon this quite a bit when I talk about fatigue. And again, I think it's probably one of those elements that gets overlooked as an actual postural challenge. It could be the only dominant driver is somebody's positioning within the chair. If somebody lacks the sitting tolerance, maybe because they've been confined to bed for months, they haven't been given the time to adjust to a sitting position. Again, postural care has to be gentle and gradual to work. And then if we're expecting them to, on the very first day, to sit out for 8 hours, they simply don't have the endurance to do that. So they fatiguing quickly, which is then the reason why they're presenting. So they may have good range of movement. They might not have any neurological impairment, but they're still presenting in this way because fatigue and the influence of gravity tends to exaggerate any asymmetries. So I think it's something that does get often overlooked. And sometimes we just need fatigue strategies and energy conservation strategies, such as pacing, rotating equipment, having a timetable in place. And sometimes it's okay to go back to bed to have that rest and recuperation. As I said, it can involve certain strategies, making sure that's clear in the care plan, using different functions. There are things that we can do to the chair itself, so they don't actually physically have to change the chair, but still allow periods of rest and recuperation, like using tilting space and leg rest elevation if it's appropriate for them. But then there may be a need to rotate equipment and have different seating objectives from different support surfaces. A big part of energy management is understanding that tolerance. So again, there may be a process, especially if it's a completely new sit-in strategy or lie-in strategy or nighttime positioning, that there's monitoring in place for the first few weeks, you know, and a gradual increase in that to try and improve the tolerance and endurance. So monitoring forms and timetables, so you can get that quantitative but also qualitative feedback from caregivers potentially on how long they were able to tolerate for and how quickly we can progress through that care plan. And then moving up then to the most complex cases where sadly an individual's been referred and they're already presenting with these contractures and fixed deformities. It does happen even with with working on education and raising awareness. There are still going to be individuals who are lost to the system, who lack the interventions that they need. They could be from very loving families who have been happy enough to just plod on and don't want to cause a stir, don't want to reach out for help, until suddenly it hits crisis point where there's elderly parents, and then this individual should have really had the proactive approach done beforehand, but now we have to be reactive to that. It's also understanding as well that there are risk factors that we can do with people that we work with to limit how much soft tissue shortening happens. We can't cure the neurological impairment, but we can understand the risk factors that may increase the risk of soft tissue shortening, such as prolonged periods of time sitting, not having a regular change of position, not having a range of equipment that can be utilised, not being on the right medication. Maybe they need to be referred for spasticity management or Botox clinics, that holistic MDT approach. You might be the first person who's even noticed that they have these tonal changes. There might be a new neurological event that's happened that nobody's been aware of, and that's a powerful place to be in to do that signposting. Just to say as well, I know we're focusing on neurological impairments. You don't have to have a neurological impairment to be at risk of a contracture. Any individual, as I said, if I made you sit here in one position without any kind of compensatory movement or subconscious postural changes, and you was in one position for 10, 12 hours a day, especially if somebody's confined to bed where that could be their life 24 hours a day, there is going to be soft tissue shortening and sadly the risk of those bony changes from happening regardless of any neurological impairment. So we need to be proactive in those cases where we can be as well. The presentation obviously is going to dictate, and the driver of course is obviously going to dictate the solution, and then this is where we are moving up then in complexity to the type of seating system that we can be used, and the priorities do shift as well. We're now going into more of the accommodating rather than forcing correction, supporting our asymmetry rather than trying to fight it. Things like contoured cushions or custom seating, tailored support, or even moulded seating systems may be indicated. But then there's that fine balance between having, in an ideal world, somebody would have a wheelchair that maybe had that custom moulded so that they're safe and secure to access the environment and the community, but then they have specialist seating to allow a bit more flexibility and a bit more freedom of movement for rest and relaxation and activities at home, and then nighttime positioning and supine positioning support as well. So there's that rotation between changes in position. We then obviously moving up to more multi-segmental support where we are adjusting potentially each body segment, but differences to left and right as well, especially those of you who maybe work within stroke or within cerebral palsy, where there may be differences from left to right, but also upper limb to lower limb as well. And then Les can maybe show you briefly some of those changes and solutions that we can see in the chair and the differences in options. Pressure care goes hand in hand with postural care. We can't say this enough. Of course, the way somebody sits is going to affect the pressure that's going through a specific body site. We can then integrate this into our seating support. And I guess when we talk about neurological impairments, a big part of this is this sustained, prolonged sitting. And that's something to be really proactive about. Another thing to be mindful of is shear and friction. And again, we've done a for Stop the Pressure campaign, which is every November. We've done a webinar last year, every year we've done one, but basically highlighting how postural care can support pressure care, and things to be mindful of, because certain functions like back angle recline can actually increase shear if we're not understanding the dominant driver. If somebody who lacks pelvic stability, for example, we open up the hip angle and suddenly that tone shoots through the roof and they slide down the chair. The same goes for things like positioning aids. If we're not understanding the cause of a posterior tilt, for example, and we're just going in straight with a positioning aid without actually trying another option and understanding what's driving that, we're fixing the pelvis, but actually that movement is still happening. So suddenly the ischial tuberosities could be causing that really deep damage to the tissues underneath, because the skin is still intact. And that's quite a scary place to be in, because the damage then gets missed, and it's not as obvious until too late, because it's not necessarily the surface of the skin, but in those deeper tissues. But again, that's something we can kind of highlight and talk through when we do the seating assessments together. Pressure care, of course, there are things we can do. It goes hand in hand with postural care, making sure that we get as much alignment and stability as possible, making sure that the chair dimensions are set up for the individual, making sure that we get even weight distribution, which is essentially as much of the person in contact with the chair as possible. But ultimately, all the research shows that the best proactive method for preventing, because of course we want to prevent, not just be reactive, is to encourage this regular position change, which reinforces the need for postural care changes as well. And again, this would be part of a 24-hour care plan. I can't tell you how long that would need to be. It's individual based. There are nice guidelines that can give you some guidance. So, for example, somebody at risk every 6 hours, somebody at high risk every 4 hours. That still seems like a very long time to me for somebody to be in one position, but at least it gives you some guidance you can work with. Some individuals may need to change position every 15 to 20 minutes, and that would need to be reflected in the timetable. We, of course, then have the overarching impact of all these different postural challenges that we see in terms of limited engagement and interaction, and the risk of them being able to lead meaningful lives. One, the risk of not protecting the physiological health, so developing an infection or an illness that means they are hospitalized or they become confined to bed. There is an element of increased risk of health problems. It could be, when we talk about severe postural deformities, the very nature of the neurological impairment may mean that they lack the independence to be able to change or protect their body themselves. When we talk about things like interaction and engagement and the involuntary movements that may be impacting on that, are there seating strategies that we can do to try and normalise that a little bit? But where possible, using the chair to encourage movement around the environment, essentially, thinking about transfers, but also the manoeuvrability as well of the piece of equipment and how that works with the caregivers. And again, we can have a look through the chairs, but there are different things we can do. And the main thing is really asking the question, what do you want to do in sitting? And that's something that often gets overlooked, because we can get so focused on clinical objectives and clinical correction when that's not always the focus, but actually asking what you want to do in sitting, what do you usually do in sitting? And that's how we get that compliance and that consistent use. And it means that we are then ultimately improving their well-being and quality of life, which is why we do what we do, right? We need to think about different accessories as well to promote that, potentially trays, making sure we have adequate foot support, and even things like environmental controls that are integrated into the chair. And then that's something we can talk through as well, and see whether that's something we can support through the seating strategies. So all this then formulates into a safe and effective care plan. Making sure it is simple to follow, include timetables where possible, and I can't emphasize enough the importance of using visual guidance. Words are great, but they can be interpreted in different ways, so where possible, using photographs, giving them cues for different repositioning strategies, so that it's very simple and easy to replicate from day to day, using outcome measures and monitoring charts where possible. Which then feeds into, this continuous evaluation. Nobody is static. Life is dynamic, and that's why the body is, and that's why we have to be responsive to that. And postural care has to be dynamic as well. Needs do change, especially within neurological impairments. That could be a progressive decline. It could be improvements in rehab potential. So we need to be able to adjust to that and address those challenges. Not only is that important for the individual, but that will hopefully stop the intensity, the complexity of the interventions that you need to do as well. And hopefully by having that care plan in place, so the individual, even if you're discharging, people have those risk factors and know when to re-refer in a timely way, so that you can be proactive with that, and it stops the need for more intensive interventions. And again, that's something we've got templates and so on around care plans, and that's something we can support you with. Okay, so let's have a look. Sorry, Les, I haven't left too much time again.
I'm used to it.
But just to have a really look at, some of these things I've mentioned, some of these words I've mentioned around tilt in space, seat dimensions, to make it less scary, especially if you're new to seating. They are medical devices, but we try and make it as intuitive as possible.
So we've got 3 chairs with us here today from the Careflex range. I'll work through the 3. Multi-adjust, mild to moderate postural care. Whilst the Smart Seat Pro, more complex capabilities with this chair, and a chair that's aimed specifically at a certain client type, the Alpha Care. So if I start with the multi-adjust, and I'm going to work through the chair in the same order that Rebecca went through the various postural challenges. So I'm going to make sure I can get the chair on the screen. There we go. So we always start at the pelvis. So I need to be able to adjust seat width and seat depth on this chair. And because of the limited time, I can't really go into a lot of detail with how I'm adjusting things, but needless to say, they're tool-free. I don't have a spanner, I don't have an Allen key. If you want a bit more detail on how to adjust the chairs, we're more than happy to come out and spend some time with you guys to run through a chair. Or you can use the website. On our website, we've got a series of how-to videos, and it'll show you everything I'm about to do with this chair. So I'm going to adjust seat width, simply by moving the arm out. You can adjust the arm height. Again, there's a little lever that's hidden away here that we just pull out, and it allows us to adjust. With the arms, we can help manage adduction and abduction. We can have one arm or the front of the arm higher, the back of the arm lower, vice versa, depending on your client's needs. Seat depth, another key adjustment. It's a lever on the back of the chair here. I'll just put my hand behind it so it stands out. That's a lock. So if I need to adjust the seat depth, I twist that and hold it down, and I move the back in and out over the seat. So if I want to increase or decrease the seat depth, I hold that lever down, push the back away from me to decrease the seat depth, drag it back towards me to increase the seat depth. Key adjustments on a chair to achieve pelvic stability. Rebecca also mentioned tilt in space, also helping to manage the pelvis. So tilt in space, the back, the seat angle remains consistent, doesn't change. We have back angle recline, which is a set and lock off. I'll bring this chair to show you what I'm doing there. Tilt in space, lever on the right hand side, squeeze, adjust. Just move it to where it's most appropriate and most comfortable for your client. Back angle recline, we want to negate the potential of accidental adjustment of the chair. So it's a double lock. So if I want to adjust the back angle, I need to unlock it. There's the little lever, you probably can't quite see that. Squeeze it, adjust. When I release it, you hear it click. That's locked it in place.
For this type of client group, which we work with people with neurological impairments, back angle recline is one of the ones I would spend some time just assessing whether it's appropriate. Obviously we need to accommodate the appropriate hip angle, but then for daily use, is it something that we need to consider making very clear in the care plan that isn't adjusted? We need to find innovative ways of locking it off, because it's one of those ones that when we open up the hip angle, we can see those abnormal movement patterns increase. So yeah, just be mindful of that.
You can see I've also got a pelvic belt here to help with pelvic stability. We can use a 2-point pelvic strap, a 4-point pelvic strap, or a groin harness. You can also use a chest harness on the upper body as well. Trunk support. What we've got here is a contoured back. I'll try, that's better. You can see the contour shape there. It prompts somebody to sit into that midline position. So when it's in place, I sit back in the chair. Just holds me in that nice midline position. We've alternatives to the contoured back. Once we have somebody who's a little bit kyphotic, and we want to use a little bit of absorption to support, make an allowance for that shape. The waterfall back. With the waterfall back, I can have adjustable laterals. Or I could use a flat back. Adjustable laterals as well. You'll notice I'm taking these backs in and out very easily. I mean, I did prepare for the presentation, but they're just held in place with clips. They just clip onto pre-drilled holes in the back of the chair, so adjusting them and changing them is really an easy thing to do. With the flat back or the waterfall back, I can use an adjustable lateral. So that will sit there, I can move that up and down, in and out. We just introduced the flip away lateral, so I'll just show you here. Just pull a little knob up on the lateral and flip away.
It can be really helpful, especially if you work with individuals with those abnormal movement patterns, where you know, the transfers can be quite a challenge, especially if you're hoisting. It means that you can flip them the way to allow more space to be able to get somebody positioned well, but then they return to where they need to be without, you know, worrying that they're going to end up as bookends or doorstops.
We can fit a pommel to the chair. All the chairs with me today are manual, but we do powered versions as well. We can power tilt and leg rest. We normally recommend a manual back angle recline to avoid that kind of unnecessary and overuse of that feature, because it can destabilize the pelvis if we don't use it with consideration.
Yeah.
Headrests. This is a soft profile headrest. We use different shaped headrests, different thickness, different densities. Can open up the back and move the padding around so that the support is in the right area for somebody. That's a whistle stop tour. I'm just giving you a flavour of what we can do with the chairs, really. That's the multi-adjust. Moving up in terms of complexity, and a kind of the Smart Seat Pro. The leg, I didn't actually mention the leg rest on the multi-adjust, but it's the same as the Smart Seat Pro. So there's a flip-up foot plate with a negative angle leg rest if needed.
When we talk about the critical angles,
side,
you know, understanding what knee ranges, there are then tailored solutions that we can build upon if that's not enough of a negative angle.
It's also angle adjustable as well. Take that away when it's not in use. So that's the same mechanism that's on the multi-adjust as we have on the Smart Seat Pro. The arms are very similar as well. We've got seat width adjustment, arm height adjustment. There's a little lever in here to just disengage. And that allows me to adjust that arm width. Seat depth, very similar mechanism to what we've got on the multi-adjust. Just turn that lever and pull the back towards me to increase the seat depth, away from me to decrease the seat depth. The major difference, you can see, it's quite obvious, it's the back. It's a full section multi-adjustable back. I bring it to you first of all to show you the adjustments on the back. Use your tilt in space lever, tilt in space, BAR, back angle recline, TIS, tilt in space. Little levers here, which I just release. Now that that lever is released, I can move the section which relates to the lever in and out, up and down, sideways, and rotate. I can be accommodating a fixed asymmetrical posture. Could be bringing somebody back to a midline, accommodating a heavy lean. Little knobs here as well. So just loosen off and I'll show you what I can do. So with somebody who's taller, perhaps I've got that fixed posture going on. See, these wings are adjustable here. I could have somebody with a kyphosis. That off. Very difficult to imagine somebody who'd sit in a chair like this, to be honest, but it'll give you an idea of the complexity that we can accommodate with the 4-section multi-adjustable back. Lateral adjustment. Lateral support. We've got built-in lateral support for the chair, which can be moved up and down, in and out. We'll flip away version of this as well, but you can see the ergonomic shape of this. It just grips here. So that's one style of lateral. We have a kidney pad as well, again for trunk support. So if you have somebody who leans heavily, or perhaps you've got a scoliosis, spreading the pressure over a greater area to release that pressure or reduce that pressure. And a pommel. With the Pro, the standard pommel is adjustable laterally. So for example, if you have somebody with a wind sweeping posture, we can't put the pommel in the middle of the chair, we need to offset it. There's a bracket on the underside of the seat cushion that allows us to do that, so we can move that across to either side. Flying through these, as I said, if you need to see them in a bit more detail, I'm happy to come out to you.
I just wanted to kind of give you a visual, you know, because there's some, obviously it was a quite theory based, and I may have mentioned terminology that might be new to you, so we just wanted to, you know, consolidate that with visual, you know, just really tilt the space of back angle recline, especially if you're new to kind of specialist seating, but then also how, you know, there's so many options. There has to be a comprehensive assessment, and we have to focus on that clinical reasoning to be able to choose from this vast selection. And Les only has one van, so we can't be bringing everything else. Yes, we need to narrow that down, and we need to maximise the seating assessment as well. So by investing in time in the postural assessment beforehand, it means we can maximise and collaborate better together for the seating assessment.
So this chair is called the Alpha Care. We make a number of postural allowances, I guess, Rebecca, would be the best way to describe this. Yeah, it's a compromise, isn't it? It's a compromise. The easiest way to think of the chair is to think of the client or the client type that the chair was designed for. And that's where perhaps the goals are as much about safety, stability, robustness of product as is the posture that's involved with the chair. I just click and lock the leg rest that away. I put it side on. We can't really just define this as a mild or moderate or complex chair, because it's going to be very specialist needs. The individual using it might be very active. So when we're thinking about, you know, advanced dementia, Huntington's disease, maybe some of the neurological impairments where there's involuntary movement, physically they may be very able, so don't really necessarily fall into complex postural needs. Yeah. But the specialist need is keeping them safe in the chair and trying to promote those normal movement patterns. We're thinking of somebody whose movement may put the chair at risk of tipping over, falling out of the chair, breaking the chair with that uncontrolled or semi-uncontrolled transfer into the chair, drop into the chair. One of the key features, or the key feature, is the angle of the seat and the back and how they work together to help manage fatigue. You can just about see here the angle. It's quite a steep angle. It's a joint movement. The mechanism is joint. As we recline, the seat drops, with the aim of getting the pelvis below the knee so that we've got gravity helping to manage the fatigue and help manage that posture. The leg rest is used to get as much of that person in contact with the chair as possible. Hooks on or clips into the front edge of the chair here once I put the lock off. That's the multi-adjust. Sorry, that's not the alpha care. I'm getting tired. So there we go. That's a quick whistle-stop tour of the SmartSeat Pro multi-adjust, the alpha care.
Yeah. And really just highlighting the importance of that assessment of clinical reasoning process, so that we can understand the drivers and then define what the root cause might be, and then be able to prioritise in terms of, you know, that systematic approach to specialist seating. I noticed there were a few comments on there about wanting templates for the care plan, so we can send that out when we send the presentation and the video out. I can get hold of some care plans that we've worked with some trusts and teams before to try and help them develop. And obviously they're quite comprehensive. It's about taking what you need from there and trying to make it as simple as possible. Just an A4 page, sometimes with an image, helps in the timetable. But yeah, I can share some of those. Yeah. I'm not sure if I couldn't see any other questions on there. I don't know if I've missed them on the chat. I don't seem to be able to access it.
I mean, if there is anything and we've missed you, please feel free to drop us an email at info@careflex.co.uk.
I think somebody maybe just asked about the orange chair. Sorry, we're mirrored in the images and the wrong way around. SmartSeat Pro 2, well as is there.
What was the question?
What the orange chair, what was called, yeah. SmartSeat Pro 2, Alpha Care.
Multi-adjust.
Have I missed any other questions? Let me just have a quick check. If we have, we'll get back to you.
And just to remind you again about our roadshows, our next roadshows are in June in the southeast. I'm sure Kiwi will post the relevant information on the venue and how to register. We'd love to see you in the skin, so to speak.
Somebody are asking, you know, about transfers, particularly Sarah Steadies. You know, specifically the SmartSeat Pro 2, but it's probably worth mentioning.
The multi-adjust.
Yeah, and the SmartSeat as well. Multi-adjust and SmartSeat. Yeah, does the Pro 2 work well? A lot of it is going to be down to the individual and how much they can engage with our transfer. You know, have they got the ability? Notoriously, you know, the Sarah Steady, the pelvis doesn't seem to fall quite in the right place. They still have to have that element of being able to take the pelvis back in the chair or reposition them afterwards. So a big part is how actively they are engaging in that transfer. The space is there to enable it. Yeah. As you can see the shape, you can see the shape of the
So we would tuck the leg rest away into a negative angle.
SmartSeat Pro as well is the same.
Chamfered edge here, plus the arms of the chair are called transfer assist, where they chamfered.
And you can have that on smart, because they're asking specifically about the SmartSeat Pro 2.
You can do
so that can do this. You can see the chamfers for the paddles, like I said, you can have that on the SmartSeat Pro. Shaped as well to be able to flip up, tuck it under, just to get the legs in better. So it would be a case of trialing with individual to see whether they can get their bottom back far enough within the chair.
I think I said earlier that it's very difficult to give an absolute definitive yes or no. It so much depends on the ability of the person being transferred with a stand assist.
Yeah.
Transferred to a chair.
But they are designed to take that into account when we've done focus groups and case studies and chair trials to try and think of every potential scenario. So we've done what we can design-wise to enable that as much as possible.
With a multi-adjust, for example, that'll tilt forward slightly, 5 degrees forward, to get the client's feet flat on the floor onto the plate of the stand assist hoist.
There's one other question here. I work on an acute stroke ward. We are currently completing chair audit and will likely be purchasing new chairs. Would you recommend the SmartSeat Pro or the multi-adjust for patients with stroke and reduced sit imbalance? I mean, ideally a mix, because it depends on the individual, you know, how complex you need to go.
Yeah, I'd say 8 multi-adjusts and 2 SmartSeat Pros, please.
Yeah, so it depends. Yeah, ideally a mix so that you can have the option. In most cases, you can adjust this chair enough to be able to, you know, this is designed for a multi-user, multi-adjustable, hence the name, environment, to try and have the options to be able to target, you know, 8 out of 10.
And 8 out of 10, based on our kind of statistics, if you like, on what we actually sell. would be that kind of setup, which would be the
we mirrored in the
which would be the contoured back, the chamfered arms, and the standard negative angle on the leg rest. That would be a standard spec, if you like, for the majority of people we see on a stroke rehab setting.
But we obviously know there is an element of complexity with some individuals who will have those significant challenges, and they may actually need the multi-adjustability on the Pro. So a mix would be ideal, as Les said, kind of
81 to the other, please.
80%, and then the remainder may need the adjustability initially. I mean, they may be able to transition, but yeah, that's kind of historically, anecdotally, that's what we've seen.
That's the feedback that we get.
Yeah. Hope that helps. Can't see any other images, and appreciate that we've run over like we usually do. Those that join us most weeks will know that we run over.
Yeah.
Anything that you do think of, you'll kind of get a follow-up with the recording and the presentation. So just respond to that if you have got any queries, if you want to reach out with any other feedback or support with anything. And yeah, our next webinar in June. Yeah. And no doubt you kind of get the newsletter if you signed up for that. But thank you for joining us.
I'll see you all soon.
Yeah. Have a good day.
Bye-bye.
Bye-bye.